Good afternoon, everyone. Welcome to this eco session, continuity of essential medical services during Ebola disease outbreak. Welcome, everyone. I think we're going to get started. Welcome to this session. Can you all hear us? Give us a thumbs up if you can hear us. Okay, so this session, I'm going to introduce my fellow panelists. We have Dr. Christophe Pansereko. He's a consultant physician and head of clinical services at Entebbe Regional Referral Hospital Isolation Center. Maybe he can introduce himself. Yes, Dr. Christopher. We can't hear you. I don't know if it's an audio. Dr. Christopher, we still can't hear you. I can see that you're talking, but I can't seem to hear you. We still can't hear you, Dr. Christopher. And the rest of us here, can you hear me? Yes. Okay. So in the meantime, as Dr. Christopher is trying to figure out his audio, I'd like to introduce our other panelist, Dr. Pascal Pio, a senior consultant physician at Gulu Regional Referral Hospital. Kindly unmute and introduce yourself.
Thank you so much, moderator, and everyone who has got the time to attend this webinar. Dr. Pio Pascal, I'm a consultant physician at Gulu Regional Referral Hospital. Thank you.
All right, we're so glad to have you. Dr. Nsereko, maybe we can try again.
Can you hear me?
Yes, now you're loud and clear.
Oh, thank you for having me. Dr. Nsereko Christopher here. I'll put on my video so that people can put a name to the face. So, Chris Nsereko here. I'm a consultant physician from Entebbe National Isolation. And my prayer is that no one comes to Entebbe National Isolation. But moderator, thank you for having us here. Let's see what we have. Thank you.
All right, so glad to have you all on this session. This session you're going to discuss, is the patient with fever, is it an Ebola patient or a malaria patient? How do you differentiate? How do we keep ourselves safe? And how do we go about it? Our first presentation is going to come from Dr. Christophe Nsereko. Are you ready to present? You can share your screen and you can start with that presentation.
Okay, thank you, moderator. Yes, just give me a few minutes. Are you able to see my screen?
Yes, we can.
Am I loud? Am I loud enough?
Yes, very loud and clear.
Thank you. So my name is Chris, as usual, and that's. But before I give this presentation, I want to honor the people of Professor Alison and Tony and Dr. Jane. These British ID specialist, but our very own also Dr. Musoke from Mulago National Isolation. So at the end of this objective, colleagues will be able to to look at the epidemiological and clinical criteria to recognize and screen febrile illness, but also to look at the IPC aspects. The initial assessment, how do you go about this patient, and of course the supportive care. Very importantly, we will identify patients who require isolation testing referral and escalation of care, and describe the importance. Why do we need to continue? When there's an outbreak, there's always a break in the communicable diseases service. So we'll look at that, and then we shall look at the few cases I've been able to manage. So at the end of this session, the audience should be able to assess, triage, investigate, and manage patients with febrile illness during an Ebola outbreak, but while ensuring continuity of essential, and I've underlined that, essential health services and preventing transmission. Why preventing transmission? You agree with me that these diseases actually fight those who fight them. So that means me and you who work in the hospital and then the patients. But on overview, VHSF include water viral hemorrhagic fevers, where even we have this Bundibujo EVD. It's a spectrum of relatively mild to severe life-threatening diseases characterized by sudden onset. I like that word, feverish syndrome, malaise, body weakness. All of us have felt. Actually, for the men, even stress can cause us fever, bleeding, and shock from blood of loss. Of course, there are multiple modes of transmission, but you can see here, what I've put up here is a game meat, which will look at that. So management of a patient with a febrile illness requires a balance for early recognition of Ebola versus continued care for common causes of fever. For example, malaria, bacterial infection, and respiratory conditions. However, when this patient walks into your facility, I hope we have our colleagues from the private settings, because of the recent outbreak, one of my colleagues actually was hesitant to yield in some of these people who had come in contact with this lady. But it's very important for us, our IPC. If I have colleagues here who work in the security, that's the armed forces, one of the things they tell you, soldier, where is your weapon? So for us as health workers, which are our weapons? The IPC, infection prevention and control. Hand hygiene, not mentioning the 5 moments of hand hygiene. I won't go through that. But here the key word is appropriate PPE according to the risk assessment. For example, you look at this coverall, you look at the head cap, and then the gloves, and then the gumboots, and then the face shield, and of course, this scissors is just for us to a marker for marking who's this in this coverall. But all of us are now very familiar, because I think having come out of a bad pandemic, COVID, and the rest, you can see how these our colleagues down were dressed up because they are going to airlift a patient. Very important to maintain physical distance from other patients. All right? Very important. Actually, for me, when they bring a patient, a suspect, when I receive this referral form, I first keep off a distance, about maybe 2 meters. Of course, this patient limit unnecessary procedures and contacts. You agree with me that some of our colleagues actually who got infected, for example, we had a radiographer who did the scan on that lady without gloves. So unlimited procedure. For example, for us, when you come in with suspect, we pick off samples. After picking off a sample, we continue giving you care, as you will see. But in the meantime, we are not going to do other things like ultrasound, like a CT scan, because we want to limit exposure. But I added this bullet, special attention to referrals. If you're working at a referral hospital like a tertiary institute, and someone says this patient most likely has Ebola, and you don't heed to that, it may be a problem, because your colleague assessed first. All right, so this is what I'm talking about. On my left, which should be on your right, you see someone swabbing the patient. Remember that Ebola can be also in the pharyngeal airways, okay? And this lady was a contact of the a confirmed case. But also on my right, which is your left, you look at that gentleman, the way he's dressed up. He's a lab technician picking off a sample from one of the clients. Yes. All right. Sorry about the background noise. I hope you can hear me. If you can't hear me, let me know. So the key question always we have, does my patient have EVD? All right. Very important. These are the questions you're going to look at. Does the patient have a contact with a confirmed or probable case within the last 21 days? Remember, the incubation period is 21 days. Attendance at funerals or contact with the bodies from certain death, from undocumented death, is also very, very important. The other is residence or travel to unaffected area. For example, if I got a health worker right now coming to my unit with fevers and then has been in Obundibujo, it would be a challenge. This one, contact with sick patients, unexplained illness or death from unexplained illness, is also very important to take. Also occupation exposure. Is this a health worker? Is this a laboratory staff? Is it a burial team? What we call dignified burial teams. But once you have that positive history, sorry about if once you have that contact history with any of sign of that, that means the patient may have Ebola. So these are some of the symptoms. These are some of the symptoms: fever, muscle aches. This slide is not as important to me as this one, ladies and gentlemen. The natural history of EVD. When you look at my left, which should be on your right, look at those symptoms. So we begin slowly, like someone said, process by process. All right? Fever, a bit of headache. It may be treated for malaria, extreme fatigue because of viremia. Then after that, you'll develop this sore throat and diarrhea and vomiting. Actually, blood diarrhea is part of the late symptoms. Definitely, you come in crashing because of electrolyte imbalance with delirium, sometimes convulsing. And that's what we are saying. The Ministry of Health is advising that any uncertain death, especially, and we can't explain, we must take off samples for EVD. All right? Now, so where are we culprits? We are culprits. If you can follow my cursor here, you're working in ICU. This patient is bleeding. He's coming in respiratory distress, what we call acute lung injury or septic shock, and is in respiratory distress. You want to intubate because everything, what we call a crashing patient. A crashing patient simply means that the vitals are really going down. I hope you're still with me. Please, if I'm not, you're losing me, let me know. So the next step, you have to determine whether the patient meets the suspect case definition. So if you have contact, you have one of the symptoms from this slide that I've just shared with you, then most probably that patient meets the case definition. So what should I do? I have been moving around, and one of the I encourage every health facility to have their response plan, have a holding area. For example, if this patient is in OPD, have you made a tent where you can put this patient or identify the youth? Have relevant public authorities notified, for example, here, the Ministry of Health, your regional outbreak commander, and then what's going to exonerate you? You may not be lucky like me. May I work close to UVRI, Uganda Virus Research Institute. So whenever I have a suspect, I just take off samples, my team. But you must now, your primary goal should be to categorize this patient. Is he a confirmed or unconfirmed? So your role should be to take off a sample, all right? And that. Then definitely continue with the supportive care while waiting results. What do I mean by this? If a patient needs IV fluids, put on. If the patient needs paracetamol, put on. However, we have said minimize in any other procedures, imaging studies, CT scan, minimize until there is a setback. I'm happy to inform you that the results will take about 6 hours, 6 to 8 hours PCR results. So, if a patient does not meet the suspect case definition, please allow them to continue. Now, colleagues, this is where it has been. I know I've isolated the patients and the results come out negative. And when I take these patients to the ward, people sometimes think that they still have, that maybe the results were not correct. No, colleagues, they were correct. All right? They were correct. So my advice, once the patient doesn't feel, trust each other. All right, we are continuing. So also evaluate for alternate common diagnosis. For example, malaria, typhoid, pneumonia, urinary tract infections, meningitis, and all the others. All right? And also, very important, of course, we didn't see this, but COVID is also a possibility. But with the sepsis, you may get what we call hemolytic uremic syndrome. I won't go into that. But remember, as you pick off these samples at the bedside, you can do a malaria RDT. You can need an HIV screening, and this you can do a urinalysis, because these are rapid diagnostic tests. All right. Now, very important. I'll put this info. However, if you suspect other viral hemorrhagic fevers, for example, Marburg, apart from EVD, you should use appropriate biosafety precautions. Now, initial clinical management. Now, you have this patient has, you're suspecting, is in your holding place that you identified with the hospital management. What do? Use the people that have experience. But remember always, the BADE system never disappoints. Never check on this patient alone. Use the BADE system. Assess the vitals and hydration. Make sure that the patient is able to drink something, but also make sure that the patient, you administer some drugs to take down the fever, but also look for alternate diagnosis, and that one I'll make it evident when I go through my case vignettes. All right, so ABCD, as usual, medical school, don't forget. But once the patient is to the end stage, for example, needs ICU, be careful. I'll share with you my story. But never forget ABCD approach: airway, breathing, circulation. For this, please, it's important to concentrate on circulation as you're waiting for the results. All right. This pictorial graph is so important to me. Why? This is the first contact that I had contact with an Ebola suspect. I know you can't recognize me there, but I was deep in Western Uganda there. And I was working with one of now the big men I won't mention because of the privacy. So you can see, you see us the way we are dressed up. All right, IPC. But on my right, look at that mother with the suspected baby. We are also helping her, although she's not dressed up like us health workers, but we are protecting her still. So do reassess frequently, monitor your patient. I've written there IPC at all times, colleagues. Never forget IPC. It's your weapon. Just like a soldier, a weapon is his line of defense. That's our line of. So you can see us there changing the drip. You can see, of course, this was our holding place. You can start checking on the fluid balance. Mental status, very important to check. Supportive care should not be delayed while waiting results. We will continue supporting the patient. For example, the patient has MRD positive. Remember, there can be co-infection. We will still give the antimalarials, colleagues. I love this slide. All right, I love this one. So what I've been trying to elaborate in the last 22 hours, that you have a patient who's a suspect, please don't touch the patient with your naked hands. When I was training as a third year many years ago, I was in labor suit, and now it brings me, I was in labor suit working, and this mother came in. I don't know if you call it a second stage or third stage, I'm forgotten. But I wanted to receive the baby with my naked hands because I was young. And the midwife actually slapped me. I am looking for her so that I can thank her, because by that time we didn't have PEP. All right. So for you as a health worker, IPC, there is no emergency when you have a suspect. I'll repeat that. Safety first. So after you have the appropriate IP screen for epidemiological list, go through the checklist. Where did this patient come from? Where did they go? Is he a suspect or not? Is there something that obviously explains his symptoms? If yes, what else? But also consult your senior people. I always ask, and then investigate. Remember, your target is to make a diagnosis as possible. And because Ebola response is a national response, everyone will support you. Every day I receive phone calls from my colleagues around, and I really support them. I've never left them alone. So we'll always support you. We'll be there for you. Okay? Support you. So isolate and test, and keep that patient isolated until you have results. All right? Essential communicable disease survey should continue during the outbreaks. But okay. So continuity of this is my part of this talk. What is when we have this kind of everything? For example, one day I was making a joke. I was sharing a doctor's meeting, and I said, if I collapse here with diarrhea, many people would run away, including where I am right now. Okay? But never forget, for us, we have physiology, biochemistry, we have learned all those things. Put them together. But also important that we don't abandon. We will include with the other services, maternal and newborn care, child care services, non-communicable disease, and surgery. All right? Okay, so communicable diseases should continue during an Ebola outbreak. Very important. You remember our experience in actually during COVID pandemic, where there was a lot where you were required to get clearance, and we saw so many people suffering. But we are thinking that now, actually, this disease, other services should continue. They should be maintained. They should not be disrupted. If they are disrupted, they should be restored. Why is this important? It's important because people will continue having these diseases. It's important because it helps us to treat the treatable diseases, but also it helps us also in surveillance. All right? Now, I want to go into that. Maybe when I share my slides, you can go into that. Of course, these are the communicable malaria, tuberculosis. Remember, disseminated TB involved the lungs, the chest, and everything can affect, can give you actually a picture-like syndrome of Ebola. The other one is HIV, very important, and these sexual transmitted diseases. The lab, very important to continue testing while maintaining IPC. And yes, very important. Now, this one is also about continue indices. What are some of the indicators that we run in a hospital to make sure that we are still carrying out the other diseases are being treated? These are some of the things that will follow up. All right. Mortality, case fatality rates from other diseases, are they increasing or decreasing? For example, one of the studies that I did with my colleagues from South Korea was to look at, was there more death during COVID because there was lockdown or not? All right. You can look for our paper. It is available. All right. Why do we need to continue these communicable diseases? Because in controlling this malaria and that, we reduce the panic on the population. So it improves outbreak control, but also breaks the outbreak of other communicable diseases because people are abandoned. There is also preservation system leading to faster recovery, and of course, it is strengthening our health system resilience. One of the things, for us in Uganda, we have a saying that inkuba ketonye olaba obusisira bwe bwenkana. For the non-English speaking, it means that let it rain and we see how strong the roofs are. So when in these outbreaks, we test our resilience, our system, our strength to control such epidemics, because epidemics take a big toll on a health system. And I want to thank the Ministry of Health who have really controlled this epidemic together. Yes, people with chronic infections Also, because we need this, they also continue to get their services. You remember, one of the challenges we had during the pandemic, the breakdown, was people who are on ART, all right? Someone missing, and then, but we found out a way how to help them. Lastly, as I part to do so, when you have a suspect, there's this, and I'm glad our commissioner is joining us. EVD is a national response. Is a national response. So when you have a suspect, don't feel like you are the one carrying it. All right, involved. For example, I put in this slide, and those slide you can see all the toll-free numbers. It doesn't pass a day before I'm called from Ministry of Health to support the nearby health facilities. However, you can't do that if you don't have a holding place. So my region is you should identify a holding place for a highly suspicious individual. You take off samples observing IPC until you get your results.
Maybe,
Now, these are the...
Doctor,
Can you hear me?
Yes, I can hear you. I just wanted to briefly pause a bit there. You introduced the aspect of Ministry of Health support. And at this point, I would like to welcome our Commissioner, Emergency Medical Services, who has joined us for this session as well. Yes.
Thank you. Okay. Yes, moderator.
All right.
Yes, thank you. Yes, Commissioner, you're most welcome to join us. We are so humbled, sir, for sparing your time to join us as the health workers in this country. Thank you. So contacting ministry, always supportive. I always receive phone calls from ministry as one of the specialists to go and support other facilities, and we have really done that. So if you're on this call and you listen to me, never get stuck. Why? Because if it is a national response team, everyone is concerned, because it won't affect only, sometimes you remember now the mother who ended up in a gyne. Actually, some of my two friends gynecologists were isolated. So EVD is not a response for only one individual, but all of us. All right, make sure you have your toll-free numbers. Make sure you have the numbers of those you can call on anytime. All right, these are as I wind up, as I land this plane, I want to share with you about what I call 4 near misses. Those who do surgeries know when I do near misses. This was a 26-year-old midwife. She was working in Kajans. I got permission to share this information, and she comes in with persistent non-blood malaria with the on and off fevers. So the risk factor here, she's a health worker. And by then we had just had cases in Chibuli. So we took around the history around Chibuli, if she has been closed, and she's working in Kajansi, movement of people in the city. And of course, there was no history of contact. So I just gave her levofloxacin and discharged her, and she's well. Then the interesting one that really was, this was a 56-year-old Indian who had lived in Uganda for 3 months and was brought in as a referral from a nearby clinic with fevers, headache, and slight confusion. No bleeding. Now, this comes back to you. I rarely do this, but allow me to go a little bit. I rarely do this in my presentation. But when you look at this picture, this patient is coming in with fever and headache and slight confusion. This side on the extreme end. All right. So many people right now, actually, they abandon the patient on me because the people who refuse it. But remember, slight confusion. However, he didn't have any bleeding tendencies. He wasn't bleeding from any side. He had no history of contact. He was just staying at home. So we did a quick malaria test, and he had 100 parasites. But he had the thrombocytopenia, and he had the AKI. So in this gentleman, would you explain? He has never been exposed to malaria, so he wasn't immune to malaria. So we had to we manage him as severe malaria and AKI and this. The other was an interesting one. Was brought in by a 10-year-old was referred from our nearby health center I want to mention, and this boy lives with the parents who are health workers. Both of them are nurses, and was brought in on. But they saw that she had presented with the fever, headache, and managed for severe malaria. Now on that too, the nurses who were taking care of him noted that he was passing tea-colored urine. So they put the boy in ambulance, ran to us that you have a Ebola suspect. But now this boy, where would we have gotten it? Because he lives with the parents. The parents are okay working. So definitely this one we just managed for malaria and sent him back. And he was well. Then the interesting one, which this one now you have to be careful. He was a 26-year-old border rider. We are contacted by our security, and he lives in a nearby vicinity. He was found in his room vomiting blood and profuse sweating. And prior to that, his friend said he had complained of fever and chills. Now, this one, you must take off a sample. He's highly mobile. He's very mobile. He moves around the town. He's coming in with vomiting, blood diarrhea. This one, you have to take off the sample. This one, we had to observe IPC at its best. Madam. Colleagues, so in my take-home from every fever is not Ebola, but every fever must be screened for Ebola. As I learned this, your IPC comes first before anything. Do not delay any essential services while waiting for the test results. We want to thank the Ministry of Health that now we can get results as early as 6 to 8 hours. Very important. Use the risk-based approach. Is there epidemiological linking? Can these clinical features be explained by other diseases? Don't forget the 56-year-old Indian man. The holding place is very important for you as you take off these samples. EVD, like any other, kills health workers and other patients. Never forget this. It will kill us who fight us. I think it's like in nature. Nature will, if you don't, or us of course for us the Christians, the devil will look for you, huh? Will never look for anyone who doesn't. So that is, if it also kills us. And you can, I have a lot of pictures, but I thought I wouldn't include them because maybe not. But very important, if you're on this call, just know that EVD is a response at the national level. Share with us. We'll be able to tell you, maybe there's something you've missed. We'll be able to tell you, is this Ebola or not Ebola? These are my references, and I want to thank you for listening and attending. And before I want to welcome the commissioner and my other colleagues. Yes, for listening, especially my colleague from Guru. You're most welcome, Doctor. I know you've been in the middle of it. And all of you who are attending, thank you very much. And I'll be happy to answer your questions. Thank you, colleagues.
Thank you so much, Dr. Christopher. Thank you for such a wonderful and well-detailed presentation. Right now, we'll take any questions that you have. Any questions from our audience? Any questions? Yes, Andrew. Yes, Andrew?
Oh, sorry, I'm muted in my
Andrew, you can unmute and ask your question.
Sorry, it's taking up.
Andrew, kindly unmute and ask your question. Okay, so as we wait for Andrew, there was a question in the chat.
Can you get me?
Yes, now we can hear you.
Yes, mine is not a question, but I'm very much grateful especially being a neighbor here in South Sudan. And all these cases can affect us in every step. And the presentation itself is very, very nice. And people, we really understand it. And we are able to get it and follow it. And we wish that even as we continue discussing, we also have to look at the mode of care that we give, and how do we apply some other modules that we have to such a case if it's like Ebola. Like, for example, maybe palliative care. How do we apply palliative care to a patient to Ebola now that is an emergency? And here we need all these precautions. Are we together?
Yes, we are. I think Dr. Christopher is going to respond to you.
Otherwise, we'll hope that you'll send for us these notes, because we can use with our staffs here in the field, and we'll keep on maybe joining from time to time with those ones who will feel like joining from this side. Thank you.
All right, thank you so much. Dr. Christopher is going to respond. Or would you like to collect all questions?
I think he wants
Yes, we can moderate. We can maybe collect some questions and then maybe 5 and then we answer.
Okay. All right. There was Olivia. I don't know. You keep Oliver. Oliver Nakajubi, you had your hand up.
Yeah, good afternoon, colleagues.
Good afternoon.
I hope I'm loud and yeah. I would like to ask something that is practical. Actually, the situation I'm in right now. I wanted to know, how long does it take for someone to show, like someone who has handled some suspected person? How long can someone be checked? Like, when do I expect my blood to actually show the results if I'm exposed to someone? Because as for me, just a few days ago, we had a big burial. And of recent, my father-in-law developed some flu-like symptoms, then malaria, was tested positive for malaria. But then after some time, he has begun vomiting. He has hemoptysis. And I was then trying to help him around. So I wanted to ask, like, if I were to be tested, how long does it take for the results? Is it okay, like even as early as yesterday, for the tests to show positive or negative, and how do we have to manage? I don't know, I think I missed some session somewhere, but also management of the asymptomatic, because for him he's already there, they have taken the blood off, and I think I stayed behind for this session. However, I was really worried about that also.
All right, thank you so much, Olivia, for that question. We have another one from Christine. Yes, Christine, you can unmute and ask your question. As Christine is unmuting, we have one from the chat.
Good afternoon, everyone.
Good afternoon, Christine.
Yes, I'm Christine from Nebi District, West Nile region. I would like, in the first place, I appreciate the presenter. Yeah, he elaborate more on the IPC, but my question is, and I need help. I'm a midwife by profession. Like in antenatal, the queue might be long, not might, obviously, it is always long. Then during palpation of mothers, I want to get clear whatever. should we put on disposable gloves like for each mothers, or you put on one, you palpate all, or you use sanitizer, or you palpate one, you can't wash? Let him first give us at least one thing that can help us. And if we see like you put on a glove, you change for this mother, the other one you change. Hospital economy is also behind us. So he should first give me way forward, actually. Thank you.
All right, thank you so much, Christine, and thank you from joining from Nebi District. I'll take another question from the chat. It says that, are we saying these near misses were not tested, especially after we established we can have co-infections? Then we have another one that says, how do you differentiate Ebola from other hemorrhagic diseases? And are we doing lab tests for other hemorrhagic diseases? I think that brings us to about our 5 questions for Dr. Christopher. I think you can start from there.
Thank you, moderator. Thank you very much. And thank you, colleagues, for asking those questions. I'm really encouraged. And thank you for your kind words. So the first question was our colleague, Andrew, who is in South Sudan, is talking, of course, definitely your request about the slides. We will share them through the secretariat. Palliative care in the EVD. Do you have palliative care in the EVD? I think palliative care, no, by the time the patient actually is too sick, sometimes this patient, for example, the palliation part of it would be if this patient, all the organs, the kidneys have shut down, the liver is not working, he has brain death, and then you have to explain to the attendants. But these patients, when a patient reaches there, that time, you may not have the time actually for that, because they go down. Once you remember the other slide, I went even back again to just show you. Once they reach that terminal end, things go very fast. They go into cardiac arrest, and even you may not have time to explain to the attendants. And that explains why EVD bodies are extremely infectious. I don't know the pathophysiology behind, but Dr. Pascal, my other senior colleague, maybe knows why EVD, when you're about to die, the virus comes on your skin. And so the bodies of people who have died from Ebola, they are so highly infectious. And that's why we say that in that instance, there's no much role of palliative care in EVD, because it doesn't give us, once a patient goes into DIC, they deteriorate so fast and die. Oliver, you asked a very important question. I would want to give the practical aspect of it. What do I mean? For example, if we get contact with a confirmed case, we self-isolate. To begin with, the incubation period for Ebola is up to 21 days. What does that mean? That you within 21 days from your contact with a confirmed case, you can get symptoms. So what do we practically do? For example, for me, when I get in contact and I didn't observe IPC, we self-isolate for 21 days. During that self-isolation, we receive psychosocial counseling. Because there are two things. It's like doing an HIV test. It's either negative or positive. So even you who has come in contact, either you return, you will seroconvert, or you remain negative. So we receive psychosocial counseling. But every day, remember what I talked about, that VHFs are characterized by a feverish syndrome. That's why it can mimic flu. That's why it can mimic enteric fever. People like diagnosing enteric fever. So we monitor our fevers every day. They will give you a thermometer to monitor your temperature every day. So once you get a temperature, a fever, then we know we take off your sample PCR, all right, to see. All right. So a documented fever, and I know will give that. So how can you manage now yourself? I think I'm glad, I don't know where Oliver, you can take my phone number in case you need more help. I can be able to help you. You can take my number if you're available. I'll just put it in the chat, and then you can contact with me to help you more. But I am praying hard that Mzee turns out negative, but we have a team to support you, including our colleagues at the Ministry of Health. So we'll support you, but there's no test, as much as I know, that we can do while you're still asymptomatic. And someone who has no symptom can't spread the disease. That's why a patient who has Ebola is less likely to be in the supermarket shopping. Why? Because a fever, if you have fever and diarrhea, you can't go to the supermarket. And that's why it's easier to control than COVID. I'll stop it there. So Oliver, I'm going to put in my phone number. We can join. I can, if you need more help, I'll say, but you let us know about also Mzee. Christine from Nebi, my sister there. Well done. Thank you for saving mothers up. Yes. Now, Christine, again, I don't know if you came in late in my presentation. I showed you the spectrum. I don't know, presenter, if you can just allow me to throw it up again. I can just throw it again for the audience, so that moderator, so that, you know, I like teaching, so you'll excuse me, but this is this slide here.
For us.
Yes, that, don't forget it. Now I'm answering my midwife from Nebi. Yes, remember, your mother may have a fever or Viagra. Now, it is a standard practice, colleagues, the 5 moments of hand hygiene. Sister, you can use soap or you can use a sanitizer. But for you, I would really expect that before you palpate another mother, before you take the fundal height from one mother to the next, you sanitize with your mask on. All right? With your mask on. So that in that way you prevent. But when you look at, let's go to this other where my cursor is. So, sister, your patient who will come in with diarrhea and vomiting is not going to end up in antenatal. This one will be on the ward. All right? And so I'm thinking, sister, your risk is too low for our mothers that just walking in the health center and walking. Maybe a fever. Okay, they may have a fever, but less likely will be. So for me, sister, for you, the practical aspect would be palpating from one mother to the next. Please observe the standard IPC that you do when you're doing a ward round, hand washing and sanitizing. Alcohol 0.05% is very important. So sister, that is for you. And of course, make sure that for your patients, as this one comes, I know I've been worked up country, they come with their laces. Laces are small causes. Someone puts their lace, they do and go. But sister, you're less likely to come in contact with a mother who has a full-blown Ebola because of this slide there. So sister, from Nebi, just observe the standard practice, the hand washing. And yes, I think that's it. Then I'll go to another, the near misses. As I've said, what makes us doctors is you have the science, or a nurse is you have the science. Now the other man, let me give an example. The other man who was malaria non-immune, coming to us with the confusion, AKI and severe malaria. Why do you want to do Ebola PCR? This is what happens. Once you mention this is Ebola suspect, it means the dynamics will change. Okay? It means actually we are going to put him in our holding area. That means, remember, he has AKI. He needs a constant IV fluids. He needs to give his attention on time. So once you have another explanation that's so obvious, with no epidemiological link, what does epidemiological link means? It means I have contact with the confirmed, like Oliver has shared, or I was in contact with a person who died suddenly. I've been working in Ebola treatment unit. There must be a linkage. In Uganda, they say akakwato. Okay? Like some linkage. So without that linkage, we don't get Ebola from air. So without that linkage, there's no way. And that actually that gentleman is alive after dialysis. So the dear misses, we miss them. Then can we test for other viral hemorrhagic fevers? The answer is yes. But I think, moderator, it would be unfair for me to finish this without inviting in my senior colleague, Dr. Pasco, to say something, especially about palliative care in EVD, but also to answer Oliver's question about management of asymptomatic. Thank you. I do submit.
All right, thank you so much. Dr. Pascal? She's responding to the questions in the chat as well. So for those, some of questions, she has been responding to them.
Okay.
Yes, but you can hear something from her.
Yeah, thank you very much, colleagues and all the people who are attending to this webinar. It is a very important webinar that we need to pay attention to, and would like you to be in touch with any of us if you are challenged with any patient or
Dr. Pascal, your network is...
you are not clear of the presentations and the questions, some of them, to the questions online, and people will read from there. But it's very important that a patient who is near dying, we should not leave the patient alone. We continue caring for the patient. You do all that you can, but in that you need to protect yourself, because a patient who has reached that climax has a high viral load, that all the surrounding is full of virus, that in case you have a breach in PPE, you are likely to get exposed. We are not saying that Ebola patients who are dying should be left alone to die. No, we continue to support them until the Lord calls them. This is what I can say, including the dead bodies. After they have died, you know that the virus is still very active and alive. Any patient you have been caring for and you are not sure of the diagnosis and you have been suspecting Ebola, please handle them with appropriate PPE. You need to actually assess the risk so that you choose your PPE accordingly. I would like to stop here so that we have the presenters continue. I'll be responding online. Thank you. Over.
All right, thank you so much, Dr. Christopher and Dr. Pascal, for that wonderful. We're going to go on to the next presenter just for the purpose of time. So as you're loading onto the next presenter, thank you so much, Dr. Christopher. Maybe just a small addition for my midwife from NEBI is, even when you're not dealing with patients, our mothers during this outbreak of Ebola, as midwives and as nurses, we have to take caution in proper hand washing from one patient to another. There are other skin infections, there are other diseases that we can transfer from one patient to another just by not using proper hand hygiene techniques. So let's use our sanitizer, let us use our gloves where appropriate. And also for our mothers, before they join the queue in antenatal, we should set up a triage station. Let someone have people taking temperatures, assessing these mothers for whether they can actually sit in a queue or require urgent attention. So thank you so much for that wonderful engagement. We are now going to go on to our next presenter, our commissioner, Dr. John Baptist Wanaye, going to tell us about the leadership structure for Ebola virus disease outbreak response in Uganda currently. Thank you so much and welcome so much, Commissioner.
Thank you so much, Angel, for moderation. I just want to appreciate the previous presenter, our consultant from Entebbe Hospital, Dr. Sereko. Thank you so much for that practical experience sharing and the lead on answering questions. Dr. Pascal, both of these doctors have lived it in the real trenches in responding to Ebola response. Members, I'm going to pass you through leadership structures for Ebola response, because where there is no leadership, then things cannot go on. Proceed. We shall go through that, some bit of introduction, the leadership hierarchy as it stands, MOH, the National Task Force, pillars, activation of the incident management system, and what is there today, and why do we say that Uganda always succeeds in some of these things. Now, I've organized this in two sets, the National Task Force, which has the Strategic Committee, the Scientific Advisory Committee, Top Technical Advisory Committee, and the Public Health Emergency Operational Center, IMT, which under it are the pillars. Now, that is the Ministry of Health organogram. I know it is congested, but it suffices to tell you that it has 19 departments and 3 support units. The 19 departments under public health, we have 7 of them. And when you look at the Bundibujo Ebola response, that Directorate of Public Health is the one which takes lead. And you will see, when we go ahead, you will see the role of those last 2 departments, the National Laboratory Department and the Integrated Epidemiology and Surveillance as our entry point. Then from there, the Directorate of Curative, which has nursing, clinical services, pharmacy, and emergency medical services. And therein, you see the other pillar of case management. Then we have the Directorate of Strategy, Policy, and Development, wherein is planning and health infrastructure, human resource development, and the other. Then you have the Directorate of Health Governance and Regulation, which has 2 departments. Then you have the last part, which has again the 2 departments. So in summary, there are 19 departments and 3 support units. The support units are very important. Sometimes we don't take them very, very importantly, but in them, internal audit, procurement, public relations, and the other 2 departments which are not directly clinical are finance and administration, then human resource. They determine a lot of what the other departments deliver. Now, in this response, usually whenever there's any epidemic or disaster, the department or the ministry responsible in this country is the Office of the Prime Minister. Now, the Office of the Prime Minister delegates to the responsible technical ministry. So if it's epidemics, that responsibility is delegated to Ministry of Health. If it's from animal area, it is delegated to the responsible ministry. If it is to do with water disaster, it also goes there. So for our case, we handle National Task Force on behalf of the Office of the Prime Minister. Now, the National Task Force can be escalated to be chaired directly by the Prime Minister herself, depending on how extensive the epidemic is. If it is maybe affecting one district or within the country, Ministry of Health may be able to handle. If it has a lot of implication regionally, Office of the Prime Minister. If it has international connotations, then the cabinet gets involved. Now for Bundibujo Ebola virus disease outbreak, the National Task Force is led by Her Excellency, the Vice President. As you know, Ebola has international effects, so the office of the president is directly responsible. And the National Task Force has so many membership institutions from Ministry of Health departments and divisions, as we saw in the organogram. We have other institutions like UVRI, our national referral hospitals like Utavika and Mulago. Then we do have other institutions, proceed. We do have other institutions like the Public Health Emergency Operations Center and the Public Health Fellowship Program. I think all of you could have heard about this. Some of you who want to get more expertise in response to epidemics, the Public Health Fellowship Program exists, and it has so many tracks. You should be able to do at least one of them. We have other government ministries and departments mentioned therein, but I will mention mainly MAIF, because MAIF deals with animals, and most of the viral hemorrhagic disease outbreaks is usually from animal to human being, zoonotic causes. The health partners, the leading is usually the World Health Organization, the US CDC. You have seen this outbreak. I should have bolded that Africa CDC. For the first time, Africa CDC has come on top, which is sort of leading the partnerships. We have UNICEF, you said, others, you said, I think I should have deleted it. They deleted it last year?
Yes,
I need to delete it from this slide. Many of our partners, AFNet, Uganda Red Cross, Seed Global Health. I do not want to forget Seed Global Health because we are working very closely. And the technical chair of the National Task Force is the Director General of Health Services. I think you all by now know him, Professor Oraro Charles. And the co-chair is the World Health Country Representative. But should it be a disease, a zoonotic disease outbreak, then you have the Director for Animal Health co-chairing with our Director General. Proceed. Now I'll go to the Public Health Operations Center. This is the technical arm which coordinates our epidemic outbreaks. The incident management system is the operational structure which helps us to ensure that we are responding effectively. And the incident management system is usually set up by the Director General, and he appoints someone called incident manager. And for Ebola response since 2022, we have had the incident manager, who is Colonel Dr. Chove, deputized by Mr. Atek. This time, Mr. Atek, who is the deputy incident manager, is the full incident manager for the individual Ebola response, because the Colonel has been doing an extra course. But right now, I think he's back. He's going to be deployed in DRC. The incident management is designated to lead the incident management team, and its overall responsibility is to assemble and provide consolidated information to management before the National Task Force takes a decision. This IMT is the one which generates and compiles information for the National Task Force to take a decision. Then there are pillars under which the IMT operates, and 8 of them are active now, but they may range from 7 to 14, depending on what the National Task Force designates. Now, we shall look at these 8 pillars, which include coordination, surveillance, laboratory, case management, risk communication and community engagement, logistics, continuity of essential services, And this I've called it pillar 8 security, but in the real structure of pillars, you don't find it listed there. But for this individual response, it is an arm which is responsible. In most cases, they embed within the existing other pillars. Now, here we go on to break down sub-pillars which exist in each pillar. The coordination or the strategic management committee, for it has no sub-pillars. It is a coordination structure. But surveillance has 7 sub-pillars, which is data management, points of entry, active case search, event-based surveillance, alert management and rapid response, contact tracing and case investigation, quarantine management. While laboratory has 2, sample collection and transportation and laboratory testing. The third pillar, which is case management, it depends on the outbreak. This time, actively, it is having 6: infection prevention and control, clinical care and management, emergency medical services, mental health and psychosocial support, nutrition support, EVD survivors, safe and dignified burial, wash, and therapeutics. But those, I put them in red because sometimes you find them in the other pillars, as I will explain in front. Continue. Now, risk communication, community engagement, and social mobilization has the following. It has 6 of them. Community engagement, where they do house to house, and this is usually our VHGs and CHOOS. Then we have risk communication, we have social mobilization, we have public awareness. Public awareness is really what you see on social media, electronic media, the mainstream media, and PROs. Then we have health promotion for message generation, rumor monitoring, evidence generation, and demand generation. Usually, why this is important, if you have an epidemic and there are no rumors coming, there are no alerts coming, then you know there is a big problem. It means the risk perception in the community is very low. So you must generate it, and that is where that issue of generation comes from. Mass gathering, this becomes key in situations where you want to control the outbreak, because it can mass gatherings can become super spreader events. And I wanted to show you these books which you must read. The first ruling is the Public Health Control of Ebola Virus Disease restriction of entry into Uganda from DRC as one of the orders which the president issued. Please, you Google this instrument and read it. It gives guidance why we should control the way people are entering the country. Another one, the Public Health Control of Ebola Virus Disease. Number 2, rules 2026. Again, His Excellency, the President issued this. It is called Statutory Instrument number 46 of 2026. The other one is Statutory Instrument number 47 of 2026. So these are important documents which all of you should use and try to understand some of the decisions or the rules which we are using in the country to control. Continue. Now we have logistics and medical countermeasures with 3 pillars: fleet management, non-medical logistics, and medical logistics. And this is where you find people like pharmacists, transport gurus. Others are called really logisticians. This is where they play their part. Then we have continuity of essential health services, which Dr. Serko has emphasized so much about. And in it, it has those 4 sub-pillars: health promotion, environmental health, disease prevention, community health initiatives. All of that is a public health component. Then you have the second one, which is on communicable diseases. How do we continue to make sure that HIV, malaria, TB, all these diseases are being prioritized in our care? Then the non-communicable diseases, you know that they are now becoming lead killers: diabetes, cardiac, cancer, lung diseases. Then you have the common one, which I saw the lady in Nebi asking a question about: reproductive, maternal, newborn, child, and adolescent health. Now, I just wanted to just show you that pillars can be up to 14. Now, in the Africa CDC coordination mechanism, they are 14 to that extent. And I will just quickly pass through and say number 1 to number 5 are largely the same as we have in Uganda. But you find pillar number 6, infection prevention control, combined with WASH, safe and dignified burial. Then you go to pillar number 7, which is research, knowledge management, and access to medical countermeasures. Then you go to pillar number 8, operational support. This is logistics and workforce deployment. Here in Uganda, we are using all those arms, but we are just taking advantage of the management of the permanent secretary to complete that. Pillar number 8, continuity of essential services, is the same as what we have. Pillar 10, artificial intelligence analytics and threat assessment. And 11 is on preparedness and readiness. 12 is on One Health. In the last outbreak of 2025, we had One Health clear, and also in the one of 2022, One Health was a full pillar. Then humanitarian response and service delivery is 13, while prevention and response to sexual exploitation, abuse and harassment, and safeguarding is pillar number 14. This is one of the big areas. If you have attended WHO trainings, SEHA is one of the really emphasized areas, and that's why it appears here as one of the 14 pillars. Now going into some depth, coordination and leadership. Strategically, we want to have a well-coordinated, rapid, and effective response by mapping and engaging all relevant partners at the national and subnational level. We want to establish a strong leadership at national and district levels through the activation of task forces, effective coordination of efforts. Largely here is we don't want everyone to act on his own. We want people to be coordinated. And here, number 1 is we map and coordinate partners at national and subnational level using the 4W partners matrix. We activate task forces in high-risk districts. You have seen we listed 37 districts where we are taking as very high risk and prioritizing. Facilitate national pillar task force meetings, district task force meetings, and coordinate early action reviews. In surveillance, we need a robust surveillance system that ensures early detection, investigation, and contact tracing. This is one of the areas which really makes either the response to be effective or not. And some of the activities undertaken is to ensure that investigation materials, case investigation forms, SOPs, community and health facility EVD case definitions and other relevant guidelines are available, distributed, and now most of them are on the e-platform, would then to mentor also health workers on mortality surveillance. You saw what Dr. Sereko was telling you about mortality surveillance, mobilize and mentor teams at the lower level. This is usually done by districts. Then in terms of contact tracing, this is one of the key sub-pillars which ensures that every contact is known, is identified, is managed, because sometimes it is from the contacts that we can have super spreader effects. Then active search right now for Bundibujo Ebola, it is being done effectively in Kampala, and we have follow-up almost at every health facility. Points of entry, emphasis is being put on the DRC, Uganda border, right from West Nile up to down here in Chisoro. And the whole things to ensure that whoever is entering the country is screened so that we identify people of public health concern. And specifically, we are not allowing people from who have visited the Ituri province to enter and just mix. They come in and they must be monitored for 21 days before. Then we have quarantine. Quarantine, this is where all those who have had close contacts, we make sure that either it is self-quarantining or there are some official quarantine sites. The ones we have had in Kampala have been so helpful because we identified the places and where all the contacts were quarantined, and almost about half of the positives whom you hear about came from the quarantined people. Alert management, this one, they deal with orientation of surveillance teams at both national, district, and regional level. This conducting population cross-border assessment activities in high-risk districts, then also orientation of border health teams. In laboratory, already, most of you know this, laboratory capacity is strengthened to support effective sample collection, transportation, and testing. And the laboratory, I'll tell you, becomes the heart, because you cannot diagnose a case of Ebola without a confirmation. So the activities which this pillar is dealing with is updating lab stocks, deploying standby sample transport systems. All of the 37 districts, they have done this. EVD collection materials, orientation of management teams, then setting up rapid response teams in districts, and risk assessment. And also what is key is that decontamination of the labs. Whenever a lab handles a case, you must be able to decontaminate, because they may be testing malaria, but they have tested a positive Ebola case. And that means that all of that in area is contaminated. If you do not decontaminate, it means whoever will come in to use, you will pass on the infection. Like for now, we have deployed the mobile labs in Wera and the Arua, which are doing a good job. There is, as I said, EVD laboratory capacity building. There is a training of laboratory staff. There is results management. The results management also, the commissioner lab usually leads in this, and every morning they have to give us a report on what which how many samples they have tested, what are the results. Then we need to, of course, facilitating sample collectors, preposition, and so on. I want to tell you that Uganda, in terms of laboratory diagnosis, we were, the outbreak in Congo had lasted almost 1.5 months without actual diagnosis. But here it took 1 day and we got the results. So we have a robust laboratory system. That's why you see Uganda announced on 15th and also DRC announced on 15th. So you see that. Yet in DRC it had started 1.5 months. But the reason was that when the Ebola was not being looked out for, and when you are doing testing, Ebola Sudan and Ebola Zaire are the ones which are commonly tested for. Case management, this is a comprehensive case management of cases, prompt treatment, effective care of the suspected, probable, and confirmed cases. They are responsible for deploying rapid case management SAG teams, orientation of health workers on IPC and case management, provision of case management for admitted patients, and also home decontamination, discharge packages for survivors, and case management teams at the district level. Right now, it is only, I think, one district, Oli Health Center. I think it is in Zombo, or maybe I forget that, but it's Oli Health Center where there has been at least a setup of an holding unit. Continue. IPC is under case management, but effectively this is to do with robust infection prevention and control, waste management and isolation in both the treatment center and quarantine centers, IPC surge teams, and also they guide in the IPC commodity procurement and provision of job aid materials for the healthcare workers. And Dr. Sereko was very clear that IPC is our shield. It is our shield. Without IPC, we cannot survive as health workers. And if you want to bring down the healthcare system, you just have the health workers without IPC, and the whole Ebola management system will collapse. Mental health, psychosocial care is very important, and it is key that we ensure that there is support to both the health workers and also the patients and our communities. So there should be provision of the interventionists for psychological first aid and counseling, training responders to deploy counselors at isolation, quarantine, and community levels. And the most difficult people to counsel in this response have been the health workers. Yes. And the most difficult were doctors. And I think too much knowledge can be a big problem, because when a senior consultant gets exposed, counseling him to accept that actually he has been exposed is a very difficult thing. And that is the experience, but a lot has been done and they have been reached. Provide child care and protection services, conduct home visits, conduct health education talks, provision of condoms, conduct serial viral testing, and support research teams. It is important, especially the child care. In this response already, we have had a mother and a child infected. You can see that complex, and a situation where the mother heals, but the baby is still ill. So the baby cannot remain. The mother is negative, but has to be with the baby. So all of this, you must prepare people to look at that complex situation. Emergency medical services, the responsibility is on timely and safe evacuation of contact suspects and confirmed cases. Our responsibilities is to ensure that the leadership and governance structures are up and running, both at regional and district level, to have human resources who are trained and ready to support this evacuation. And members, you note that evacuation of a very ill Ebola patient is very complicated because you are seated in an ambulance. It is a small chamber, and you know that this is a very ill Ebola patient, and you must continue moving and providing care. That's why we have to conduct drills and sharpen skills of the EMS people. We need to preposition these ambulance teams for evacuation. We have done relays from West Nile region to Kampala in order to ensure that these patients reach, but not also infecting our health workers. As you recall, EMS was affected badly in 2022, where we had one of our staff get exposed, and I think there were like 4 who became positive, and we lost one of them, and it was so bad. That's why this time we are taking care to make sure that people are well trained, people are using PPEs, so that our team remains solid and quite strong. Okay. The survival program, this I'll tell you is very key in the sense that if you have been following Ebola, even when we test negative, there are some privileged sites where the virus remains, and we have been told that it is in our gonads, and also in the breast milk. It stays for a long time, up to 9 to 15 months. So this is why it is important to set up and functionalize the EVD survival program, and also to monitor. You need to have the health workers support the people. Sometimes they get into complications of other diseases, which you have got to support. And if they are from different, majority of ours are from DRC. So our teams who have gone there, they have to support setting up clinics to support them, because they will keep getting complications here and there. And then risk communication and community engagement. This is a very key area to create strong public health awareness and behavior change communication, to also build trust and activate community rapid response team and ensure safe mass gatherings. The public health awareness teams, they use multi-channels and multidisciplinary professionals. They do social mobilization. And one thing I want to share with you now is that because the response is yielding results, some people in the community think that it should not have been announced as an Ebola epidemic. They think that if Uganda has all this capacity to respond, why do you even bother to announce? But without announcing, then the risk perception in the community will remain low. And when it is low, the spread will be silent, but very devastating. So risk communication and community engagement remain key, and that is what government, Ministry of Health is doing at the moment. Continue. Yes, stakeholder engagements, especially the religious leaders, cultural leaders, are very important in the West Nile region and Rwenzori region, because the people cross over, some are in DRC, some in Uganda. The cultural leaders there become very key. You saw, some of you were watching some videos where some of the communities were even you remember a health worker in, I think, DRC, a health worker, one of the health workers was unfortunately killed by the community. These cultural leaders can help community to appreciate capacity building of VHTs and CHUs, and also review production, approval, and distribution of health education materials. We have seen the SOPs, they are being done by this team, operationalization of the Ministry of Health call center, and for provision of feedback. Then still this is true. I think that is repeated slide, proceed ahead. And still we conduct rapid community readiness assessment for control measures that break the chain of transmission, and deploy community engagement teams, customize and operationalize community referral protocol, and engage community-based implementers to integrate EVD interventions, collaborate with the National Intersecretarial Community Engagement Committee. Members, you have seen the issue where we decided that some activities should not take place, especially in the very high-risk districts. If you are going to effect that, you need a lot of community engagement, and sitting down with those community leaders becomes key, and then bringing their complaints to the national level so that the decision you take is accepted by the community. I've seen some of the communities now, they are even saying, no, you have kept us closed for so long, we are losing business, we are doing what? But engagement and talking to them can be able to create the level of understanding. Logistics, mainly they're dealing with quantification of supplies which are needed, deployment of logistics teams, and ensuring that any issues of access are addressed. Some of the districts and points of entry have been telling us, I don't have this and that, and it is logistics team which can be able to address. Further to this next slide, logistics also helps us to mobilize vehicles, ambulances, fuel, and other resources. They help to coordinate movement of these logistics, and also inventory management and tracking. When you use these so many resources, at the end, when the auditors come, if you do not keep your records well, you will be found wanting, and some people will not believe that you used those mobilized resources well. So you must have a proper record, and the logistics team helps us in such. Mobile units, we have, of course, our emergency medical teams which have been deployed in Congo, so logistics might support that. Transport networks, and then post-deployment assessment and feedback. If the teams have been deployed, then have we addressed is logistics or supply chain issues? Continuity of essential health services. Dr. Stavia heads this area, and she has been running webinars every weekend. I think even tomorrow there will be one. This is like having that even if you have case of Ebola here, there are many cases of malaria, HIV, TB, maternal child health. We need to keep taking care of them. So key activities is multidisciplinary committees are established. They map the functional capacity of public and private health facilities, they redistribute and task shift health workers, train and orient health workers, provide supervision, mentorship, and coaching. Like you recall some of the hospitals where almost all the health team were exposed. Now, if you have about half of your staff as contacts, how do you continue with work? All of this is in the continuity of health services, and the team here goes and sits with management, and they plan how services should be able to continue. And Dr. Stavia has been leading us in that area. These are other pillars which can be activated, which are already commented on: WASH, vaccination, seed. Vaccination right now is not active because Bundibujo Ebola, the vaccine is not yet. But remember, in 2025 and 2022, we had the vaccines, and that pillar was very active and it was quite big. Then strategic information and research ongoing. Now, I wanted to have a comment on the UPDF support. It is involved across many pillars. They support the national Ebola response through coordination, and most of the support they are giving us is on border health, points of entry, surveillance, contact tracing, logistics, operational, especially in the insecure areas, risk communication and community engagement, and implementation of IPC and WASH. Now, this, if I give you an example of these border areas, if we are going to implement the issue of screening and we limit people from entry or exit from DRC, then security must be in support. There is one case specifically, they packed him as a good, because Uganda allows cargo to come from DRC to Uganda. So they packed this fella, but it was a patient. But the way they packed, they left some space down there for him to lie there and breathe. But they transported him, you can imagine, from Aru. Aru is on in DRC. This side is Arua. They transported him through all there without anyone understanding that there is a human being in this luggage until he reached our park here, Namayuba bus park. Then when they were unloading, then they quickly, our call center numbers called, I've reached here, I'm here, I came from DRC, Bunia, I'm a patient of Ebola. You can see. It is good that he was able to communicate, but the fact that he was packed as a good, you can see the need for health services, which is in the DRC. Someone says, instead of dying from here, let me try. Continue. The incident management system is activated by the Director General. When the Director General gets a report, he activates the Public Health Emergency Operations Center by appointing the incident manager. And the incident manager requests the heads of the pillars to assign persons into the incident management team. Then the incident management team now follows up all of these reports and prepares a case for the national task force. And from there, action is taken, and based on that report, an epidemic can either be declared or deferred. Now that is a graphic representation of what I was saying, reports rising through from the field to the operations, to the public health emergency operation manager, to the incident manager. The incident manager is the chief who informs the national task force. You see task force there in yellow. Yellow is telling you that power lies there. Then there, the Director General. So yes, that is where big decisions are made. This other side are support services. Continue.
Close.
Here, I just wanted to tell you that we still have the DRC data is not updated. I deleted it, but I think it still remains there. The current is in thousands, so there it is not correct depiction. But in Uganda, we have now up to date 20 cases, 18 cumulative admission, and 20 dead. And two dead, then cumulative discharges 14, and current admissions are 3, which involve a baby. The key thing is that we have in that team we have about 4 health workers in that report of the 20, and the health workers were direct contacts to those people who came from DRC. The other one case was a driver to one of the positive cases. So by and large, most of these cases were around the people who came from DRC. Then I wanted this to tell you that there has been some achievements. The first one is that we do not have local community transmission. And that one for now 1.5 months, we are doing fairly well. The next is that when we after discovering the other 4 health workers, we have not had any other health worker infected. So that means that the people you have you are following IPC, as it was said by Dr. Sereko. Then the case management team has done well. Fatality rate is low, and 100% of the cases we have here, the contacts are known. So we don't have any lost contact who creates fear in us. So that's why we are very strong. And when time comes and DG, the permanent secretary and the minister are going to speak, they will speak more with a lot of strength. So this one, I just wanted to tell you that despite of the good things I've said, the risk, you see there, we have those red areas. In Congo, it is burning. It is burning. So that's why government of Uganda agreed with the government of DRC to deploy our teams there to support. You see, we are very close. You see Lake Albert. Dr. Jimmy show where Lake Albert there. From Lake Albert there to Bunia, it's just 50 kilometers. I think 50 kilometers is not even up to Jinja. It is so close. So we have people can even just walk, and they are here in Uganda. Even if we say we have closed borders, but for us who come from borders, you cannot cross a border. It is very difficult to cross the border. You just pass through. You pretend, because your brother is on the other side, you go with your boats, what, and you cross. But the people you stop, like now, those who pass through the official channel, those are the ones you can stop. These ones who pass this way, you can't. But the army, police are doing a good job. They have managed to reduce the numbers. That should be the last. That was the secret of Uganda's control. I wanted to emphasize that leadership is the biggest thing. Leadership at the highest level that understands and trusts science makes the breakthrough. And there were some quotes I wanted for you, that when something is important, you do it even if the odds are not in your favor. That rich man said like that. Then another one from the mother of nursing said, I attribute my success to this. I never gave or took any excuse. So when you are responding to Ebola, Florence Nightingale's statement stands firm. never give or take excuses. And where there is no vision, the people perish. If you do not have, leaders for the vision. If they do not have it, then you will see the number of the dead we shall have. Thank you so much.
All right, thank you so much, Commissioner. It has been quite an insightful discussion and presentation. Thank you so much. We would like to take just one or two questions from our audience. We'll take just one or two questions. You have Morris Ahewa. Morris Ahewa, you can unmute and ask your question.
Thank you very much, Commissioner JB and Dr. Nsereko. I just have two inquiries, probably either of the presenters could allude to. The first one being the psychosocial aspect linked to their mode of operandum, but the forces or the UPDF during an outbreak. Point in case in the current outbreak, one of the healthcare workers in a given health facility where there were positive cases was evacuated from her workplace by the armed forces at 2 a.m. despite having 2 negative test results. Those are presented with headache and fever. But then at 2 a.m., her home was broken into, and then with threats of tear gassing her together with her 2-year-old baby. So my inquiry would be, given the stigma associated to such an outbreak, and then the mental disturbance, what would be the approach? Who would be held accountable for such an event of how this person was evacuated during this contact tracing? And then the second is the near miss cases. In this case, almost missed case. For the patient who passed on in one of the hospitals, I wouldn't want to mention. The test result, unfortunately, the patient coded, and then the team, the team couldn't bring her back, so she ended up passing on, and she was a first-degree epilink patient. So the healthcare workers who attended later on come out presenting with symptoms, and yet the result to this patient who had passed were negative. Days to come, healthcare workers who are attending tested positive for the EVD. So I want to understand the dynamics, because I know an outbreak has several dynamics that comes along with it. So perhaps either of the presenters could allude to these two inquiries. Thank you.
All right, thank you so much, Ahewa. We can take just one more person. Okay, so if there's no one, I think we're going to respond to those two questions.
Thank you, Ahewa. The first question or description, I don't know how true it is, because evacuation of patients is done by my team. It is not done by security. The security helps in tracking, like if you switch off your phone and you are a contact, then the security will help us, because they have other mechanisms of reaching, of knowing that JB is hidden in CD Global Office, and they will get me even when my phone is off. That's the advantage we have with security. So, but this issue of saying that tear gassing, that's, I think there's a point of exaggeration there, because how would they tear gas? Is this person having security, or maybe if he was also a big person with the other security people, that would be true, because they must first subdue the other security before they reach you. But I'll be able to bring this to management so that I can get other details, since you have said it was at 2 a.m. was done by security. I'll have to find out if it is true. Then I'll be able to ask the responsible people to give clarity. But in epidemic response, I want to request you members, especially the health workers, that in epidemic response, we have got to be cooperative, whether you're a health worker or a community member, because the health of the community now overrides your personal rights. If you are going to be a danger to the society, then your rights are literal. This is the only situation where you can be denied even to move away from your house, yet it's your right. This is the only situation where if you refuse to be quarantined, you can be quarantined by force, because the risk is beyond what we can be able to take. So I will only give a statement on that after getting details about it, especially from the other sources. And if this is a health worker, you should tell him or her to lodge this with the Director General of Health Services. It is an open office, and if it cannot reach there, can come direct to me. I'll be able to take her or him to the Director General. We want to know the detail of this. Then Dr. Sereko will comment on this, but what I want to say is that if the patient who passed on, if the sample is taken after maybe treating the body, chloroform, what it does, it deactivates all of these DNA things, all the tests will be negative. And the fact that that's why that case is counted as probable. The fact that the doctors and nurses got infected and they had not been in DRC themselves, by the patient they had attended to had been in DRC, it gives you that close link that it is likely that this patient, because if it was identified when alive, would have been okay. But it seems maybe the sample, because we have many different ways of taking off the sample, if the sample was not taken off rightly, then it could have been interfered with. The other thing is that WHO recommends that when you get a negative, you do a repeat, usually after 72 hours. And if it is someone who is in the quarantine, a repeat is done after 48 hours. So, but because this one had passed on, you can't have a second sample. Thank you. To Dr. Sereko, maybe to add on.
Moderator, I don't know if I'm audible. Thank you very much, Commissioner Dr. JB, as we fondly call you. Thank you very much. Yes, and thank you for taking off your time to share with us. Thank you for the presentation. Colleagues, I just want to add on what Commissioner said. One of the challenges we get is for health workers who are exposed, to refuse to be a mandatory quarantine. They sometimes actually, in that lady, Dr. JB, I would love to share. There was a senior colleague, a gynecologist. I found him somewhere operating, yet he had touched this lady. I told him, sir, you can't do this. You can't continue with the normal work. So, and I told him you can't run away. So he was running. So, colleagues, when there is a problem, I think It's good that you obey the authorities, but I've never heard of where the military picks the health workers, Dr. Hebo. I don't think but as Commissioner promised, he will follow it up. The other, and I think the second question, Commissioner explained very well. There are many scenarios, even transportation of the sample, but also the yield. Was this sample taken after the body was treated? All those are questions that we need to look at. But I think Commissioner has done a service to explain that. But remember also, Dr. Heber, even before discharge you from the treatment unit, you must have 2 negatives, 72 hours apart. Thank you very much. Those would be my humble submission. Thank you.
All right. Thank you so much, Dr. Nsereko. Thank you so much, Commissioner, for your engagement. For our audience, thank you so much. We are coming to the end of our session. I hope we have been able to understand if a patient has fever, do you treat Ebola? Do you consider malaria? And we have understood the pillars that the government supports or we go through as we are managing for those that we think are Ebola suspects. How do we go about them? So I believe now we are equipped with the knowledge. And as we go back to our health facilities, as we go back to our workplaces, I hope that we keep employing this. Please do not forget, like he mentioned, our IPC. And last but not least, remember that in management, like Florence Nightingale says, let there be no room for an excuse, because it is what is going to lead to more and further spread. Thank you so much. And I think at this point, I'm going to request all of us to turn on our videos. We take our group photo for our session. We can all enable our videos and we can take a group photo for our session. Thank you all for joining this session. Right. Okay, thank you, thank you. From those that have joined outside Uganda, we really appreciate. Thank you for joining. We have seen some from South Sudan. We have seen some who are greeting us good morning. So must be outside our time zones. We really appreciate from those in our regional facilities. We are extremely grateful. Thank you, thank you, thank you. And please, for the remaining echo sessions, feel free to join us as we continue to share knowledge.
Thank you. Thank you.
All right, thank you. Have a nice day.
Thank you. Bye-bye.
Thank you. Good. Thank you. Angel.